Welcome to this presentation on the use of the ReCross dual-lumen catheter in a complex coronary CTO case. My name is Ashish Pershad. I practice in Arizona and Dignity Health, and hopefully you find this case useful and its application will help you get through some of your more complex coronary cases. Clinical vignette first. This is a 79-year-old gentleman who had a previous bypass surgery. He presented with escalating dyspnea, which was his anginal equivalent. He underwent an MPI and an MRI scan, which demonstrated inferior wall viability, a scar in the lateral wall, and a diagnosis of an ischemic cardiomyopathy with a low ejection fraction of 30%. He underwent a diagnostic coronary angiogram, which demonstrated that his only graft that was patent was his lima. His vein grafts, the circumflex and right coronary arteries, were occluded. The native right coronary status was that it was occluded in its mid portion. There were ipsilateral collaterals from an RV marginal into the PDA and PL, and there were no left to right collaterals from either the lima or the native left circulation. So he underwent a diagnostic coronary angiogram, and then this was, of course, during the time he was referred to me for the intervention. And you can play this back, and you can see on loop that the native right coronary is occluded right at the bifurcation of the RV marginal. There are bridging collaterals from this RV marginal, as well as retrograde filling where epicardial RV marginal collaterals into the PDA. There's heavy and dense calcification of the right coronary. There's an incidental Watchman device you can see on the screen here, and there's a prior CABG, and there's filling of the occluded vein graft, as well as filling in the venous circulation. So our procedural plan was to use single access, no need for any mechanical circulatory support, because our primary strategy was going to be antegrade, first with wire escalation, and if that failed, then going to a dissection reentry strategy. A tertiary, more complex strategy would involve using the retrograde approach with the ipsilateral RCA RV marginal collateral, but I think this would definitely be a more high-end strategy, and before I went to that, I would seriously exhaust all other antegrade options. So our setup was as follows. The right coronary artery was engaged using a 7-French guide with side holes. I didn't think I needed to enhance support with an AL, so I used a JR with the planned use of a trap liner as my guide extension catheter, along with a turnpike spiral, which is my workhorse antegrade catheter. You could see brisk filling of the RV marginal as well as retrograde filling of the PD and PL branches of this dominant right coronary. The CTO itself is quite long and it's heavily calcified. So I got the guide extension down to the mid-right coronary after dilating the proximal vessel. And you can see now that there is actually a microcatheter tip that's actually left behind at the mid portion of the CTO. This was one of the challenges we encountered, which we can talk about in an algorithmic way as to how we managed to work through it. As I said earlier, I was able to get an antegrade wire into the posterolateral branch, but no device would cross. So obviously, the algorithm in that circumstance involves firstly enhancing support, secondly switching from the microcatheter that I used initially, which was the turnpike spiral, to a more low-profile torquable microcatheter, and then finally to the non-torquable catheters like the VineCross and Caravel. Unfortunately, the Caravel tip sheared off in the calcific CTO body. Strategies that we also tried and entertained were the Turbo Elite laser as an attempt to get through this long CTO, but the turbidity would not cross. I did not use laser on contrast, which would be another strategy. I was unable to free wire with the rotor wire because of the calcification of the previously present stent in the mid to distal right coronary. So therefore we chose to dissect the CTO intentionally and go around the calcium to the distal cap. Unfortunately, in doing so, I got behind the previously implanted stents in the distal right coronary. This is visualized in this image here, where you can see that the microcatheter now has gone around the cap, and we are at the distal cap of the RCA at the crux. You can also see the previously placed caramel tip, which had been sheared off the catheter in the mid body of the CTO. So at this point, we re-entered into the PDA successfully, as can be demonstrated with this tip injection, but clearly had potentially lost access into the posterolateral branch, which was not ideal. So to solve this problem, we used the ReCross dual-lumen catheter, which is now shown to elegantly reach the distal cap and is at the bifurcation with a workhorse wire in the PDA. This is a fluoro-saved loop of the real-time wiring of the posterolateral branch from extraplaque to intraplaque location using a Pilot 200 through the proximal port of the ReCross dual-lumen catheter. And as you can see, as elegantly demonstrated on the right slide, that the Pilot 200 finds the port, exits the port, and is able to re-enter the posterolateral branch successfully. He then successfully concluded the case by switching out the Pilot 200 to a workhorse wire, as can be seen by the image in the left panel, and then went ahead and, using image guidance for optimization, ended up treating this right coronary successfully with the implantation of 3 stents with successful restoration of flow in both the PDA and the posterolateral branch. So my takeaways from this case are as follows. Number one, I think the ReCross dual-lumen catheter is an excellent option for re-entry from extraplaque to intraplaque location at bifurcations. The over-the-wire configuration and the 180-degree offset allows for and mitigates wire wrap. It can be used as an alternative to the Stingray system for antegrade dissection re-entry in this case. And it also allows for rescue of side branches at bifurcations in non-CTO scenarios. Thank you for your attention.